Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week sessions again. So we're coming to the end of free sessions, right? So this is the last week of our free 2-week session. And as you know that our initial idea was that we could finish cardiology in 2 classes, but given that we have added more cages in cardiology, so we are taking 3 classes on cardio from now onwards. And tonight, instead of doing a cardiology role play, we will be doing cardiology theory session, which is class 3. So in our class 3, we are going to do a lot more discussion about few other important clusters. So there is still 2 clusters left. One is our hypertension cluster. So there are a lot of cases coming under hypertension nowadays. And also there is a cluster under palpitation. Now you can think that why we are not discussing heart failure yet? Because heart failure will be discussed under shortness of breath cluster. And shortness of breath cluster, we would discuss that in respiratory. So when we discuss the respiratory system, we will be covering the acute heart failure or some of the heart failure cluster that we get. Okay. So with our today's session, cardiology will be almost finished, and that's all that you will require for your exam. And in our next class, we will do a cardiology role play based on all these topics that we have covered. Okay, and that will be the end of free 2-week session. Next week, we will start the course. We will start with the orientation class. Please make sure that if you are willing to join the course, definitely you should start the preparation this week. And I will discuss a little bit about how the course is going to work, what the course is going to offer and all. And you can also ask questions if you have any. All right. So let's start cardiology theory session 3. And trust me, this is the first time we are doing a 3rd class on cardio. And I'm also excited to see what we can offer in this class. So first of all, we have palpitation or nervousness cluster. So palpitation cluster comes in exam, but there are mainly a couple of cases which comes under this. But we need to know how to deal with this because it's a common question in exam. So as always, if we do a cluster, we know about the differential diagnosis, we know about the history format, and we know how to do a physical exam, and then we do the cases. So what are the differential diagnoses of palpitation? So the number 1 important is cardiovascular disease. So ischemic heart disease, myocardial infarction, hypertension, any arrhythmia, which is the most important, valvular heart disease, or even heart failure patient can come to us with palpitation. Then CNS could be any of these. So CNS causes of palpitation are not that important. This does not cause palpitation a lot, but still we keep this under this cluster because palpitation and nervousness, we do it together. Some of the patient will come to us saying that I feel very nervous these days. So if we are getting a nervousness cluster, this is exactly the same history, same differential diagnosis that we are going to follow. But if it is a palpitation, then CNS causes are not that important. This is more important if a patient comes feeling nervous. Then we have endocrine cause. After cardiovascular, endocrine is very important cause of palpitation. So what are the endocrine causes? Could be hyperthyroidism, so that's important, hypoglycemia, and pheochromocytoma. Then we have electrolyte imbalance, hypokalemia, hypomagnesemia. These electrolyte imbalance can also cause palpitation. Anemia is important to rule out. Anxiety disorder, panic or stress disorder, always it's important to rule it out. If it is a female, usually after 40, then we will also think if it can be a symptom of menopause. And then some medication can cause palpitation, but most importantly, if a patient is an asthma patient or emphysema patient, they can take salbutamol, and if they're taking a lot of salbutamol, that can also cause palpitation. Excess tea, coffee, recreational drugs, that can be a cause of palpitation as well. There are cases where this might be the only cause you will get. Like there is a case where patient drinks 6 to 8 cups of coffee every day, and that is the cause of his palpitation. So it can happen. So these are the differential diagnosis of palpitation that we need to cover. So the easiest way to remember is that we have got 2C, 2E, 2A, 2M. Okay. Now, if you remember, or even you can write like, if we think about excess tea or coffee, then you can even put it 2C3A. But it's easy to remember if you know carcinoembryonic antigen, CEA. So I just remember by Mr. CEA. Okay. So M for medication menopause, and CEA will involve 2C. So CVS CNS, 3E, endocrine electrolyte, excess tea, coffee, recreational drugs, 2A, anxiety, anemia. Now, I always like for big cluster, it's a good idea to have some mnemonic in your head. Now, if you do mnemonic for every cluster, then remembering the mnemonic will be difficult. So I don't recommend to use a lot of mnemonic for the exam, but the common cluster like chest pain, like palpitation, for common cluster, if you have difficulty to remember them, it's always a good idea to have some mnemonic in your head. At least that will help you in the exam. Okay, so these are our main differential diagnosis for palpitation. Okay, moving on, that remember I was saying there are some medication which can cause palpitation. So this is a list of medication which can come as a risk factor for palpitation. Drug-induced side effect is always a common question in exam. These are favorite questions. So the common drugs you should always remember, like if you see that tricyclic antidepressant, some of these cocaine, digitalis, some diuretics, all of this can cause palpitation. So moving on to our history format. So this is a patient who is coming to you with a sudden onset palpitation. So first of all, you will go in, you introduce with the patient, reassure the patient that you're going to take care of him, and then make sure patient is vitally stable. By now, you know how we introduce, you know how to do the hemodynamic stability, right? So we are not going to do that again and again. Once you have done the initial part, your next is palpitation. So you ask the patient that, can you please tell me a little bit more about your racing of the heart? Or can you tell me a little bit more about your palpitation? So you ask an open-ended question. Patient will give you some information, but you'll need to find out all these information from the patient. So we need to know, when did it start? Did it start suddenly or gradually? What exactly were you doing at that time? Is it for the first time? Now, if patient says, no, it's not the first time, then you need to ask detail about the previous episodes. So if patient said, no, this is not first, so then you will say, how many episodes so far? When was the first one? Can you describe what were you doing in these episodes? So get an idea that if there is any particular situation, any particular place, anything particular that brings these episodes. Even if you're thinking about panic attack or panic disorder, you need to get this idea from the patient that, like, what is the trigger? Is there any trigger factor? Then ask that how long each of these episodes last and how do they stop? Do they stop spontaneously, or you need to do something about it to make it stop? Anything makes it better, anything makes it worse. You can also ask, what have you done so far? Have you seen any doctor for it? Have you done any investigations? So if there is a previous episode, we can ask all of these questions one by one. Okay, so you asked about palpitations. So ask about all these important questions. Find out how many times this happened, how long each of these episodes are lasting, and what brings it on, how long it lasts, and how do they stop spontaneously, or you need to do something about it. Okay. After palpitation, any palpitation can be associated with dizziness, lightheadedness. It's a very common associated symptom. So along with the palpitation, do you also get dizzy or lightheaded? And then we go to all the differential diagnoses one by one. So first for cardiovascular, any chest pain, shortness of breath, any nausea, vomiting, excess sweating, any relationship with exercise or exertion, any swelling of your feet. So chest pain, shortness of breath will cover ischemic heart disease or MI. Same nausea, vomiting, sweating will cover the same thing. Any relationship with exercise or exertion. If it only comes with exertion, we will be looking towards cardiovascular problem, because cardiovascular issues usually commonly associated with exercise or exertion. And swelling of the feet is for heart failure. Then we have CNS. So quickly ask some of the CNS question. Any headache, any problem with your vision or speech, any weakness or loss of consciousness. This mainly will cover the stroke or TIA. That's the only thing you really need to ask. You don't need to go in that much of a detail about epilepsy, meningitis, head injury. These are not needed to be asked. After that, we go to the endocrine causes, which are more important. So for hyperthyroidism, have you noticed any recent change in your weather preference? What do we mean by it? Weather preference means that patient who has hyperthyroidism, they feel very hot and sweaty all the time. Even in the coldest month, they will feel very hot. So they will say that, yes, I feel very hot this like for the last few months. So that's what we want to find out, that have you noticed any change in your weather preference? If patients say, what do you mean? You say that, do you feel hot and sweaty all the time, even if it is very cold? Patient will say yes. Any change in your bowel habit or body weight? Patient with hyperthyroidism, they can have diarrhea and they can also lose weight, even though their appetite will be normal. Still, they can lose weight. Then we have pheochromocytoma, which is a tumor of the adrenal medulla. And pheochromocytoma comes as a paroxysmal or episodes of headache, sweating, and flushing of the face. So patient with pheochromocytoma, they also have hypertension. So along with the hypertension, they get these episodes of headache, sweating, and flushing of the face. Then we have hypoglycemia. So does it happen when you skip your meal? Any history of high blood sugar? So these are your three main differential diagnoses under endocrine. So ask about thyroid, pheochromocytoma, and then hypoglycemia. Then we have anemia. Do you feel fatigued these days? Remember, only one or two questions for each differential diagnosis is enough. But if we get something positive, then we need to ask more questions. Like if this patient was saying that, yes, I feel very fatigued these days, what are the other questions we will ask? We will ask that, has anyone told that you look very pale these days? How is your diet? Do you take healthy, balanced diet? Because we know that iron deficiency anemia is common, and it is common in vegetarians. So ask about healthy diet. Are you losing blood from anywhere? Or any excessive bleeding? Or like if it is a female patient, then any excessive bleeding during your period? So these will be our back-to-back questions in those cases. So if we find something positive, then we dig in, then we go for more question. After that, sometimes even infection can cause palpitation, right? A lot of time, if you have fever, your pulse rate can go high. So any fever, cough, any runny nose, or any flu-like symptoms. So that will cover infection-related palpitation. Electrolyte imbalance, mainly ask about any recent vomiting or diarrhea, because vomiting diarrhea can cause hypokalemia, hyponatremia, which can come as electrolyte imbalance. Then you ask SADMA. So do you smoke, drink alcohol, any recreational drugs, and are you taking any regular medication? So SADMA is mainly smoking, alcohol, recreational drugs, and any specific medication. While you are on the medication, ask that have you been using nasal decongestants or any inhalers? Directly ask this question, because a lot of Australians, whenever they feel that their nose is blocked, they go to pharmacy and pharmacist will give them this decongestant. And they will keep on using the decongestant, which is not ideal, because decongestants are not the first line medication for sinusitis or blocked nose, but it's still pharmacy love to give it to the patients, and patients love to continue taking them. And decongestants can cause tachycardia. Same with the inhalers. If they're taking a lot of Ventolin or salbutamol, they can end up having palpitation because of that. Ask about, do you drink tea, coffee, or any soft drinks? If the patient says, yes, I love my coffee or I love my tea, so how many cups of coffee in a day? So make sure to find it out. Do you take any of the social drugs such as cocaine or marijuana? So you can either say recreational drugs or social drugs. Any of them are fine. Ask about their past medical history. So how are you generally? Are you generally healthy? Any past medical condition like diabetes, high blood pressure, any heart condition, any history of a condition called rheumatic fever? Because rheumatic heart disease patient also can come to us with palpitation. So we ask this directly. So high blood sugar, high blood pressure, and any other heart disease, especially any history of rheumatic fever or rheumatic heart disease. Any family history of sudden death due to any heart-related cause? If yes, at which age this patient died? So we need to know that is it a sudden cardiac death and at what age? Because many patients, especially if it is a HOCM or prolonged QT syndrome case, you will find out that this sudden cardiac death in the family happened when they were very young, maybe at 30 or 25. So it's important to find that out as well. Ask about social history. So if you have time, always say that I'm going to ask you about your home and work situation. Please be aware that this is confidential. So who do you live with at home? Is there any stress at your home? Do you work? Any stress at your work? To rule out anxiety disorder, ask about, do you worry a lot about most of the trivial things? Are you always anxious? If it is a female patient, ask about, when was your last menstrual period? Is your period regular or irregular? Do you get excessive bleeding during your period? Is there any chance that you can be pregnant? So that's for reproductive age group patient. If it is menopausal patient, let's say it is above 40-year-old and you asked, when was your last menstrual period? This is a 50-year-old patient says, oh, my last menstrual period was 5 years ago. That means patient is already menopausal. In that case, we need to ask a little bit questions about menopause. So ask that, do you get a lot of hot flush these days? So ask about hot flush. Any frequent mood swings? Okay. Then do you feel very anxious, irritable most of the time? So just ask few questions. You can also ask about night sweats. So hot flush, night sweats, mood swings, these are the commonest symptoms for menopause, but there are a lot of other symptoms. If you only ask these three, that will be enough. Okay, so this is all that we need to ask as part of the palpitation differential diagnosis. Okay, so to recapitulate, you start with the great introduction, reassurance, hemodynamic stability. Don't forget when you are asking about blood pressure and pulse, don't forget about asking pulse rate and rhythm, because palpitation cluster, one of the commonest case that comes in exam is atrial fibrillation. Okay, so when you ask about the rhythm, they can say irregular rhythm. Then you know already in your head that this case most likely a atrial fibrillation case. Then you ask about the presenting complaint, which is the palpitation in detail, and then associated lightheadedness, dizziness. And then one by one, you go to all the differentials, cardiovascular, CNS, then the endocrine causes, anemia, infection, electrolyte, and then smoking, alcohol, medication, ask about using the decongestant inhalers, tea, coffee, any social drugs, ask about this like past medical history, family history, ask about the home situation and work situation. Okay, clear everyone? Okay, moving on to physical examination from examiner. In physical examination from examiner, in palpitation cluster, what will be your most important systemic exam? Cardiovascular, definitely. That's easy. What else? After cardiovascular, what else will be important? Endocrine, yes, Dr. Shaira. So endocrine or especially thyroid examination will be really important. And then you can think of CNS and all, but cardiovascular and endocrine should be your main systemic exam. So you start with the general appearance, any restlessness, and is the patient dressed appropriate to the weather? Why we are asking this? Because hyperthyroid patient can be very restless, anxious looking, and they might not dress appropriately to the weather. Ask about any pallor, any edema, any dehydration. Pallor, definitely anemia is your differential, and edema for heart failure. Ask about vitals and BMI. Don't forget to ask about the pulse rhythm. Then you go to the neck. Always any cardiovascular system, we start with the JVP and carotid bruit, and then we do the cardiovascular as we did. So this is the same. Then go to the thyroid first. So in the thyroid examination, you will say that first I would like to check the eyes for any thyroid eye disease. And then also I would like to palpate the thyroid gland for any palpable thyroid lump. That's the only thing you need to do. So just say that you would like to check the eye for any thyroid eye disease and any palpable thyroid lump. And then say that you would also do a full central nervous system exam, including cranial nerves. You would also like to do the respiratory system for any bibasal crepitation to rule out heart failure. If you have time, you can also ask about the leg. In the leg, you can ask about any cuff tenderness and ask about any pedal edema. Why cuff tenderness can be important? Anyone? Yes, pulmonary embolism, right? Because you remember that, yes, sinus tachycardia can be found in a pulmonary embolism patient. So I would suggest that even in your history, especially when you are doing the cardiovascular, even if you just add one question here that any recent travel history, okay, any pain in your cough, any history of clot in your legs or lungs. So I would definitely say that yes, ask these questions. It's worth asking for. So any recent long distance travel, any pain or any swelling or any pain in your cuff, any history of clot formation in your legs or lungs. So just add that question as well. That will cover the pulmonary embolism. So we don't say anything. We just say that I would like to do a central nervous system exam. So just say that first you finish the cardiovascular and then you say on thyroid, I would like to check for any thyroid eye disease. Examiner will say negative. And also I would like to palpate the thyroid gland for any palpable lump, negative. Then I would like to do a full central nervous system exam, including the cranial nerves. Examiner will say that's normal. That's it, nothing else. Because this is not our most important system, we just cover it. Respiratory system, basal crepitation is important because heart failure is one of our differential. Okay? And lastly, finish with urine dipstick because infection can be a cause of palpitation. Blood sugar hypoglycemia is one of the cause, and ECG is the most important because arrhythmia is the most likely cause of palpitation. Any questions so far, guys? So this is the cluster format, and using this format, we can finish the palpitation cages. Dr. Naren, what is the specific question to ask to differentiate from hyperthyroidism and pheochromocytoma? It's quite different, right? Because pheochromocytoma patient will have episodes of flushing of the face. It's the episodic, whereas thyroid is consistent. It's persistent problem. It doesn't come as an episode. Okay, so even with the presentation, we know. No, we don't need to go into infective endocarditis or any specific infection like this. In that way, we can't finish this at all. So because you are asking about fever, if it is some infection, then it will, like patient will say, yes, I've got a fever. So without fever, we don't need to think of infective endocarditis straight away. All right. So our first case under this cluster is supraventricular tachycardia. So you're a junior HMO in emergency department. A man came in with thumping or racing heart and giddiness started today. Take history from the patient, physical examination from examiner, ask for investigation from examiner and explain it to the examiner. Explain the diagnosis and differential to the patient. That's usually one of the common way of coming this kind of question in exam. So when you ask the history according to the format, you will find out that patient has got palpitation and lightheadedness, and it started for the last 2 hours. Also, shortness of breath. Patient had 3 episodes so far, which all started suddenly, lasted 2 hours, and then stopped all of a sudden. Patient also takes 6 to 8 cups of coffee a day. No smoking or alcohol, no past history or family history of heart disease. He is also quite anxious and has some stress going on in her life. So means that sometimes you can get multiple finding. And when you give your differential diagnosis, this should be your priority. Okay, because they will give you a ECG of SVT, and that is your diagnosis. But when you talk about the differential, this should be also the first thing. So it could be anxiety because patient is anxious in nature. Could be a stress related because patient is under a lot of stress these days. Okay, could be related to excess drinking of coffee. So these will come into the top tier of your differential diagnosis in that case. Okay. So what do you see in this ECG? So this is like you took the history, you did the physical exam, then the next thing is asking for investigation from examiner, and you ask for a ECG. In the ECG, what we see that we always look at the lead 2 because lead 2 is the longest lead. Now, if we look over here, first, what is the rate? What do you think this patient's heart rate can be? So if we say that in between two RR interval, just one large square, right? So mainly like maybe one, just a slightly larger than one, if we say. So yes, it's about 300, right? And is it regular, irregular? So we can see that all the RR interval is regular, okay? Now we look at the P wave. Remember, in SVT, there will be no P wave. If you look on this, that will make more sense. So you see here that this is the R wave. This is the R. So after R wave, we have got the T wave. But there is no P wave in here. So P is absent. Then again, we have got the R. So like this is going on. So absent of P wave, and QRS is usually narrow in SVT. So you will see that it's not even one. It's not even one small square. So that's called narrow QRS. So we have got absent of P wave, narrow QRS complex, and ST wave is normal, right? So this is the ST. ST is normal, and T wave is also normal. Okay? Makes sense, everyone? So in SVT, the main finding is the heart rate will be really high. So heart rate will be elevated. Then absent of P wave. So we don't see any P wave in here. Then narrow QRS complex. ST is normal. T wave is normal. And also QT interval will be normal as well. So how we are going to explain this ECG to the examiner? So we'll say that I would like to describe the 12-lead ECG of my patient who presented with sudden onset palpitation and giddiness. The ECG shows heart rate is almost 300 beats per minute, regular in rhythm, absence of P wave, narrow QRS complex, no ST wave changes, T wave is normal in size and shape, and QT interval is normal as well. Thank you, examiner. That's all that you need to say. So right now you know how to explain the ECG to the examiner, right? So now our next thing is to explain this diagnosis to the patient. So how we are going to explain SVT to a patient? So we'll say from history, physical examination, and ECG, most likely you have a condition called supraventricular tachycardia. Do you know what it is? No, doctor. Well, let me explain. So you can always draw a picture. So you can say that this is our heart, and then quickly draw that our heart electrical impulse starts from here, and then it goes all over the heart to pump blood to your body. That's why we have done an electrocardiogram to check these electrical impulses. This was recorded, so you will be given an ECG on your hand, so you can always show the ECG to the patient, say that this was recorded when the nurse put those leads on your chest. In your case, there are some abnormal electrical impulse originating from the upper part of your heart, causing your heart to beat faster than normal. That's why you're having racing of your heart. And as your heart is not getting enough time to fill in, your brain is not also getting enough blood. And that is why you're feeling lightheadedness. Are you with me so far? This is a very, very easy way of explaining SVT to a patient. Remember, they don't care about what's going on in the ECG. You don't need to explain this is P wave, this is QRS. You don't need to do that. All you need to do is to explain it in a very nice and easy way. Okay? So that's, as long as you do that, you're good. And please do not make it complicated for the patient. And then you can say that it could be due to other causes as well. Like it could be due to a structural heart disease, something wrong in the heart itself, could be valvular abnormalities, could be medications, could be recreational drugs, thyroid-related problem, could be infection, could be some imbalance in the salt and minerals, or even sometimes excess tea, coffee intake. So this is just differential diagnosis. Now remember, if it was just a task of differential, then you need to explain why it is not any of this. So I would like to see that how you guys are learning. So is there any one of you can just unmute yourself and explain to me how would you say the differential diagnosis in this case? You right now you know, I have discussed it over the last 2 cardiology class, how to say this differential. Is there any of you who could do that? Just explain to me that how you would explain this in the exam. Anna, if you unmute yourself.
Yeah, hello.
Yes.
It could be due to other causes as well, like structural heart disease or valvular abnormalities, but you don't have any murmurs. Also, it could be because of medications, but you don't take any of them. Recreational drug intake as well, you don't take them. Thyroid dysfunction, but in this case, you will experience sweatiness or eye symptoms, but you don't have them. It could be because of an infection, but you don't have fever or any history of that. It could be because of salt imbalance, but you hadn't had any vomiting or diarrhea recently, which could lead to salt imbalance. And also you don't take excess tea or coffee.
All right. Thank you, Dr. Anna. Yeah, that's good. Very good. Let's see if there is anyone else who wants to also explain. I want you to have this way of explanation because this is a very, very important thing. Most of the cases in exam will be ended with diagnosis and differential. That's usually the face-to-face. Few of them will come with management. So if you can do your diagnosis and differential very nicely, you will be fine for the exam. So anyone else who wants to just explain that, how would you explain these things?
Yes, Dr. Shah.
Yes, Aryan, if you want to, go for it.
Yeah. Okay, it could be due to a couple of other reasons as well. It could be due to other reasons such as structural heart disease, but it's unlikely because on the physical examination, we did not find any murmur as such. It could be due to valvular abnormalities, but that is unlikely as well. It could be due to certain medications, but again, it is unlikely because in the history, I could not find any medications which would cause this. It could be due to some intake of recreational drugs, but the history is not suggestive of it. It could be due to thyroid dysfunction, but you don't have any symptoms of any thyroid dysfunction. It could be due to certain infections, but it's unlikely because you don't have any symptoms suggestive of it, such as fever or anything like that. It could be due to salt imbalance, but your history is not suggestive of any vomiting or diarrhea, which would be in its favor. It could also be due to excessive tea or coffee intake, but your history is not suggestive of it. Hence, to rule these out, still I would like to do some couple of investigations.
That's all good, Dr. Aryan. Thank you. Yes, that's really, really good how you explained it. Brilliant. Thank you. All right, so you're getting the hang of it, so I'm happy with that. So now let's say that this case is not finished with differential. They're asking about treatment. how we treat and how we explain the treatment of SVT to a patient. So for the treatment, if this is an emergency department, you will say that as part of the management, I'm going to admit you to the hospital. I'll call my senior and a heart specialist will come and review you. That's the first thing we would always do. Admit, call my senior. So you as a junior doctor, you are not supposed to manage SVT by yourself. That is one of the significant problem. A lot of course does not teach you about these things. They don't actually want you to be a safe doctor. The course that you will be doing for your preparation should teach you that, because as a doctor who is not working in Australia, you are not supposed to know this. But AMC expect this from you. And the only way you will know this is that if your mentor, if a course who you are doing, if they're actually teaching you these kind of things. Because if you don't know this, you fail immediately. I have seen a lot of courses, the mentors, they don't actually even explain that, yes, I'm going to call my senior, I'm going to call a heart specialist. Their teaching is like this, that you as a junior doctor is going to manage this SVT patient by yourself. Like, you will do everything right in the exam. You will say, yes, I'm going to do this. I'm going to put you for a vagal nerve stimulation. I'm going to give you adenosine. You fail because you will not do it in real life. In real life, this will be done by a cardiologist. Okay? So please make sure that you understand these kind of things. Without understanding the work that you are supposed to do as a junior doctor, you can't pass this exam. Okay? So it's really important that you always mention that. And after that, in the meantime, I'm going to order some necessary investigation, including a blood count to check for any sign of infection, inflammatory marker, your liver kidney functions, and also your salt and mineral balance, blood sugar level, a cardiac enzyme, only if the patient has chest pain, otherwise no need, and a thyroid function to rule out any thyroid disorders. Because you know that one of the cause of SVT can be thyrotoxicosis. Okay? So we also need to know the underlying cause, that why this patient has got SVT. As your vitals are stable, likely the specialist will first try the vagal nerve stimulation. So it's also important to know that if a patient comes to us with SVT, we always look that, is this patient stable or is this patient unstable? That's the first thing we will look. Unstable means that patient's blood pressure is less than 90/60. Patient has altered mental status, so patient is confused, and patient has chest pain. If this three is there, that is an unstable patient, and unstable SVT will require a direct or DC cardioversion. That is the treatment. And this will not come in exam, because unstable SVT usually unlikely that they will give you in the exam. So most of the SVT in the exam should be just a stable patient. So how we treat the stable patient, that's what we are going to explain now. So as your vitals are stable, likely the specialist, see that what I'm saying, I'm not saying I am going to try the vagal nerve stimulation, we are going to do this. I'm not saying that. I'm saying likely the specialist will try the vagal nerve stimulation, commonly done by modified Valsalva maneuver. To perform this maneuver, we will ask you, or the specialist will ask you to blow into a 10 ml syringe hard enough to move the plunger. So if you have never seen how to do that, so you ask the patient to blow into a 10 ml syringe to move the plunger upwards. And that usually involves the vagal nerve. Then we will lay you flat and lift your leg up for 15 seconds. After that, we will return you to the resting position for about 45 seconds. So now if you don't have time, you can always finish in here. That commonly done by a modified Valsalva maneuver, where the specialist will ask you to blow into a syringe. That's it. You can always finish there because sometimes you will not have that much time to explain all of this. But the explanation is like that. You ask the patient to blow into a 10 ml syringe, then they need to move the plunger up. And once they do that, we lay the patient flat. After patient is laying flat, we just lift up the leg for 15 seconds. And once you have done that, after 15 seconds, we will bring the patient back to the normal recumbent position. Okay? And that's called modified Valsalva maneuver. This is the most effective vagal nerve stimulation according to the RSCGP guideline and also according to ETG guideline. So that's what we normally follow in Australia as well. So blow into a 10 ml syringe, move up the plunger, lay the patient flat, lift up the leg, and then after 15 seconds, put the patient back to original position, which is recumbent position, which means this. So patient can go back to like this, okay? If the breathing technique does not work, so if vagal nerve fails, then the specialist may give you a medication called adenosine through your vein to slow your heartbeat down. It can be given up to 3 times with higher dose each time if needed. So we try IV adenosine for 3 times with increasing doses. If adenosine does not work, then the specialist will try another medication with IV verapamil to bring your heart rate back to normal. Another option would be IV beta blocker, which is the IV metoprolol. So these are our options of treating a patient who has got a stable SVT. Okay, clear everyone, the management. So first, vagal nerve stimulation. If that did not work, IV adenosine for 3 times. If it still did not work, our alternative is IV verapamil or IV metoprolol. If your heart rate still does not return to normal, the specialist might use a treatment called cardioversion. This is a quick procedure where a small controlled electric shock is given to your chest to help your heart reset to a normal rhythm. It is done under sedation, so you will be relaxed and won't feel any pain. So the last option is DC cardioversion. See that how we are explaining these things in a very nice, simple way. That's what you are supposed to do in exam. So you are always mentioning the treatment name, but then you are explaining that a small controlled shock will be given to your heart to bring it back to normal rhythm. And lastly, finish with lots of reassurance. So you will say that, John, I understand that this is scary to you, but you have done well by coming to here. And we have one of the best team of cardiologists who is going to take care of you. You are in safe hands, and we will do everything possible to make sure that you get back to normal as early as possible. If you want me to call your friends, family members, or any relatives, please let me know. I'll be more than happy to contact them. Do you have any questions? So always finish with some reassurance. And if you are not discharging the patient, we don't need to give them reading materials, or we don't need to finish with 4R in that case, because you're still treating the patient. Okay. So this is from ETG guideline. So if vagal stimulation fails, we can try IV adenosine. We start 6 milligram first, then 12 milligram, then 18 milligram. The alternative or second line is verapamil or metoprolol. Okay. And sometimes if we need to give them any prophylaxis, so if a patient getting multiple times, you can say that back to back they are getting this SVT. In a recurrent SVT patient, we can put them on beta blocker like atenolol or metoprolol, and they can take it to bring their heart rate down. Okay. So that's all that you really need to know for SVT. Nothing much will be asked in the exam. Any questions for SVT? Yes, so if in your history, if you get that this patient is also drinking 6 to 8 cups of coffee, so if that is the finding you get in your history, then yes, you need to include that in your management. That's definitely important. So you will, when you talk about this differential diagnosis, so you will always say that yes, it could be due to now even like SVT can be due to structural heart disease, can be due to valvular abnormalities, can be due to thyroid dysfunction. SVT can be due to salt and water imbalance, okay? Can be due to excess tea, coffee. So these are also causes of SVT in a way. But you can say that, but among all of these, most likely your excess coffee intake is contributing to this. Ideally, you should not drink more than 2 cups of coffee in a day. So please lower it down and hopefully this will not recur anymore. So yes, that is important to mention if you get any positive finding. Like let's say that if we found in the history that patient is under a lot of stress, we will need to address that in our management. We will need to say that as you are under a lot of stress, that can also cause palpitation. So please try relaxations, yoga, meditation. And if you feel really stressed, I can always send you to a psychologist for counseling. So any positive finding you get in the management, you need to address those. And that's important. Okay? All right. Moving on to atrial fibrillation. So you've got a middle-aged lady, 50-year-old, comes to the emergency department with sudden onset palpitation. Same questions, same task. But they added in here, explain the causes and complications of the condition to the patient. So they're asking about first, yes, history, physical exam, investigation, everything is okay. But in here, you need to talk about the cause of this condition and also the complication. So when you do the history and physical exam, like as we have done already, there might not be any specific findings except patient has palpitations. You might get that patient has history of hypertension. That's it. Have a look on the ECG. So this is our lead 2. Now ECG of atrial fibrillation can be tricky, especially the rate. So they don't expect that you will measure the exact heart rate of an atrial fibrillation patient. So ideally, we need to find out how many large or how many R is there in 25 large square and then multiply by 10. That's how we can measure the irregular heart rate. But they don't expect you to do that. So all you need to do is to just say that heart rate seems to be elevated. That's it. Nothing else. You don't say anything else because just by looking at it, you can understand that mostly the heart rate looks like elevated, right? Doesn't look like it is bradycardia. So just say that heart rate is elevated and then you can say that, see, the rhythm is definitely irregular. The RR interval is not equally placed. So rate elevated, rhythm irregular. Can you see any specific P wave here? No. We will not be able to see any P wave. So you can see that after the R, this is the T wave. Same, this is the T wave. You can't see the specific P wave. So mostly you can see kind of like a fibrillatory wave in most of the cases, like here, here, all right? So when in atrial flutter or fibrillation, especially fibrillation, the P wave will be replaced by this fibrillatory wave. So that's all you will say here. The P wave is replaced by some fibrillatory wave. QR is complex. If it looks narrow, you say narrow. This doesn't look narrow, so it's normal. QR is complex. ST is normal. T wave is normal. And QT seems to be normal as well. Okay, so that's your atrial fibrillation. Did you guys understand the ECG of atrial fibrillation? Do you want me to explain any more? So normally what we see that this is P wave like this, right? But in patient with in atrial fibrillation, it becomes like that. Sorry. So they have a T wave, but P wave becomes like this, fibrillatory wave. Okay, so the calculation of the heart rate is not needed because you will not be able to get that much time in exam. So you find out how many R is there in 25 large square, and then you multiply it by 10. Because you don't have that much time, they don't expect you to do this in exam. So please don't bother about that. So same, this is the explanation. You can always say that yes, heart rate is elevated, irregular in rhythm, absence of P wave, which is replaced by fibrillatory wave. If it is normal, then say normal QRS or say narrow QRS. Okay, so that's the ECG. Now you explain the atrial fibrillation to the patient. So from history, physical examination, and ECG, most likely you have a condition called atrial fibrillation. Do you know what it is? No, doctor. Well, let me explain. So draw a picture of the heart and say that this is your heart. The electrical impulse originates from here and then it goes all over the heart to pump the blood to your body. See, I kept it the same explanation like SVT. That's why we performed an ECG to assess your heart electrical activity. In your case, abnormal electrical signals are starting from the upper part of your heart, causing your heart to beat rapidly and irregularly. That's why you are having racing of your heart, and as your heart is not getting enough time to fill in, your brain is not getting enough blood, and that's why you're feeling lightheaded. So that is what we do. We make it simple for you as well, because you need to also understand that the explanations are not very difficult if you can make things in a same format. SVT and AF, everything I kept same. All I did is that I said irregularly in here. Apart from that, it's completely same explanation. Okay? Now, these are all the causes of atrial fibrillation. So, if the question asks that explain the causes of atrial fibrillation, then you will say that it can be due to many reasons. But in your, like, you can say it can be due to many reasons, like it can be due to high blood pressure, which is what you are having, and that most likely causing it. Could be due to a heart attack, but you don't currently have any chest pain. Could be due to any blockage of your heart blood pipes. Same, you don't have any chest pain, any shortness of breath. Could be abnormal heart valves, but you don't have any abnormal sound when I examined your heart, which is murmur. Could be heart failure, but you don't have any shortness of breath on exertion. You don't have any swollen ankle. Heart defects, which you are born with, but it's unlikely in your case, could be overactive thyroid, but you don't have any heat intolerance or excessive sweating. Could be excessive stimulant like coffee, smoking, or alcohol. Could be some lung condition, previous heart surgery, even viral infection or stress. And there are cases where there is no specific cause, which is called idiopathic or lone atrial fibrillation. But in your case, it seems like mostly due to high blood pressure that you are having. Okay? The other explanation or other task was discuss the complication of it. So what is the complication of AF? Left untreated, this chaotic rhythm can cause your blood to pool in your heart upper chamber, and it can form clot. And if this clot forms, it can easily dislodge from your heart and it can go to your brain, causing reduction of or causing block of blood flow to the brain, which is what we call a stroke. In atrial fibrillation, especially if it is not well controlled, gradually it starts to weaken the heart and lead to heart failure, which is a condition in which your heart cannot pump enough blood to meet your body's needs. So that was the main task that we have got here, talking about the causes. That's all the causes, and this is the complication. If this is it, you can finish here. But if management is a task, and sometimes I have seen AF management comes in exam, then we need to explain like this. So same thing, if it is a atrial fibrillation, we need to know whether the patient is stable or unstable. That's why hemodynamic stability is very important question. If it is unstable patient, you need to go for DC cardioversion straight away. If it is stable, then three things we need to manage. We need to find out if this patient has if you do a TATS-VOSC score to find out if this patient needs anticoagulant, because we need to prevent a stroke in this patient. So find out about whether this patient needs anticoagulant. The second, rate control medication. Third, rhythm control medication. So these are the main thing that we need to mention in the management. So as part of the treatment, admit the patient, call my senior, and a heart specialist will come and review you. In the meantime, you are going to do all these investigation. So it's the same investigation that we have done for SVT, but for atrial fibrillation, we also do an echocardiogram, because echo sometimes will be able to see if the patient already got a clot. Okay? Since atrial fibrillation increases the risk of a stroke, the specialist will consider starting you on a blood thinner such as apixaban or rivaroxaban after assessing your stroke risk. Given that you are female and you have high blood pressure, your score is already 2, which places you in the moderate risk category, meeting the criteria for blood thinner. Now, this is really important. Knowing the TATS-VOSC score is going to help you to pop out in the exam. If management comes, if you can explain like this, there is no examiner in the world who can fail a candidate. So TATS-VOSC score is this. I'm sure you learned it in your MCQ class. So TATS-VOSC score contains congestive cardiac failure gets 1 point, hypertension 1 point, age above 75 2 point, diabetes 1 point, previous stroke TIA 2 point, V for vascular disease, like patient has PVD or any other vascular disease, 1 point, between 65 to 74 age, 1 point, and female gets 1 point. Ideally, if a male has a TATS-VOSC score 0 and female has a TATS-VOSC score of 1, for them, we don't need to give them anticoagulant. Okay? If male has a score of more than equal to 1, female has a score of more than equal to 2, we go for anticoagulants. As this patient is a female and has hypertension, she already get 2 points. So yes, we are going to start the patient with blood thinner. Now, then the specialist will try to reduce your heart rate with rate-lowering medication such as metoprolol or verapamil. If that is not effective, the specialist might try an antiarrhythmic medication to bring your heart rhythm back to normal, such as flecainide or amiodarone, based on your heart function. And it's still not getting better, then the last resort is cardioversion, explained in the same way as we have done in the SVT. Okay, so if management of AF comes, you need to explain exactly like this. If you can do this, I can assure you that you will not fail this case. So TATS-VOSC score, talk about this score if you can. If you are not sure, then most of these patients actually will need anticoagulant. So even if you say that, yes, I would give you anticoagulant, they will not fail you. And then quickly talk about rate and rhythm. So this is from ETG guideline. So this is the common beta blocker that we use as a rate controller, either atenolol or metoprolol. And these are the calcium channel blocker, diltiazem or verapamil. We talked about general principle of rhythm control for atrial fibrillation. For rhythm control, you can use any of those that we discussed, which means you can use flecainide or amiodarone. And we have the DC cardioversion as well. So remember one thing, that if atrial fibrillation has persisted less than 48 hours, electrical cardioversion can be performed without any delay. If AF has persisted longer than 48 hours, then cardioversion should be deferred until patient has a minimum 3 weeks of anticoagulants. So that's not like super important for exam, but this is something you should remember for real life. That yes, this is how we would treat a patient, because less than 48 hours AF has less risk of forming a clot. That's why you can go for cardioversion if needed. But if a AF patient, it is more than 48 hours, then likely chance there might be a clot. So then you need to anticoagulate the patient for at least 3 weeks before you go for cardioversion. These are the long-term rhythm control medication for AF. Basically, sotalol is what we give. And sometimes even if we want to cure the patient, the last option is catheter ablation. So we put a catheter into the heart, find out from where the abnormal electrical discharge is coming out, and we just do ablation of that specific area. Okay, so that's basically all that you really need to know for palpitation cluster, and that's all that comes in exam, mainly SVT and AF. Any questions on this cluster, guys? Mesenteric ischemia is needed, but it will be discussed under acute abdomen, Dr. Madhupriya, not under AF. Valvular AF, yes, valvular AF treated with warfarin, that's right, non-valvular DOAC. Do we need to explain this to the patient separately? No, because we already know this patient doesn't have any valvular heart disease. So explaining extra is not needed. And that's also one of the cause of failing exam. If you say too much irrelevant thing, then also you fail the exam. So if you want to show to the examiner or to the patient that, yes, I know everything, ask me anything, that's also another problem. So you make it relevant. What is relevant for this patient? Relevant is, we know that this patient doesn't have any valve problem. So if it is not a valve problem, then we go for DOAC. And that's all that we have explained in our management as well. Okay. Moving on to our next cluster, hypertension cluster. Before we go to this cluster, let me take a 5-minute break to give you some kind of break, because there's a lot that we have discussed. And after a 5-minute break, we will start with the hypertension. All right. Thanks, guys. We'll be back in 5 minutes. Thank you. All right, everyone, let's start again. So now we are going to start with a new cluster, which is hypertension cluster. So hypertension cluster, there is no specific format. These are some random questions which come up in exam. So let's talk about the first one. So there is a case which is hypertension non-compliance case or hypertensive medication non-compliance case. Very important, comes in usually in two ways in exam. One is like this, 22-year-old. So this is one case. One is like you need to find out the cause of hypertension. Then there is another case where hypertension non-compliance is there. And then another case which is ambulatory blood pressure monitoring case. So first one that we are discussing now is the hypertension diagnosis or finding out the cause of the hypertension. So it's a 22-year-old female came in for blood donation. The nurse found that patient has elevated blood pressure on 3 readings, and she was advised to see you. History from the patient, physical exam will be given on the card, diagnosis and differential. So there are sometimes you might not see this often in face-to-face. This is usually given in online exam, but in face-to-face, sometimes they can say that physical examination finding will be given on a card, which means that in that case, you no longer need to ask the physical examination finding from examiner. Once you finish your history, you can ask to the examiner that, examiner, can I please get my physical examination card? Then examiner will give you a card with all the information of the physical exam. That is very easy because you don't need to ask anything. It's just all given. Okay, but it's not very commonly given in exam, so don't be very happy about it. So when we try to find out that this patient is hypertensive and it's just a 22-year-old female, it's not common for a 22-year-old to have hypertension. There is usually a secondary cause for this. So try to find that out. So what are the secondary causes? So we know that 90 to 95% cases, there is no cause of hypertension. Only 5 to 10% case, we get a cause. And these are called secondary hypertension. So we remember these secondary causes by mnemonic trackpads. Trackpads includes thyroid. So hyperthyroidism can cause hypertension. R for renal artery stenosis. A for aorta, so coarctation of aorta can cause that. Cushing disease can cause it. Kidney problem like chronic kidney disease, even glomerulonephritis, polycystic kidney disease. So all of this can cause hypertension. Pheochromocytoma. A for hyperaldosteronism, or which is Conn's syndrome. D for drugs. One of the common drug for secondary hypertension is oral contraceptive pill. Then if a patient is on long-term steroid or even NSAID can cause hypertension. Sleep apnea can be a cause and stress can be a cause as well. All right. So these are your secondary causes of hypertension, which you need to rule out in your history. Now from here, if you think that in the history, only thing that you can really ask is the thyroid question, then for Cushing syndrome, you might ask a little bit. Kidney problem, you can ask. Pheochromocytoma, you ask. Sleep apnea, you can ask some question. Stress, medication, these are the only thing you can ask. There is no question for Conn's syndrome. You can ask maybe muscle weakness, that's it. Coarctation of aorta, no questions. Renal artery stenosis, no questions. These are usually examination finding. So first of all, you introduce with the patient and then explain that I really appreciate that you came here for blood donation. It's really good. But when you were here, our nurse found that you have elevated blood pressure. We just want to find out if there is any cause for it. And then then find out whether we need to be worried about it. So I'm going to ask you some questions about high blood pressure and trying to find out the causes for it. Is that okay with you? Yes. So Jenny, we found high blood pressure on multiple readings. Has this ever happened before? No, doctor. Do you have any symptoms such as any chest pain, shortness of breath, any racing of your heart, any problem with your vision, any leg pain when you walk? So all of these are risk, or you can say complication of untreated severe hypertension, because untreated hypertension can cause coronary artery disease, which will be coming as chest pain, shortness of breath. Vision problem indicate hypertensive retinopathy. And these patients commonly they can get any atherosclerotic disease such as PVD. So any pain in your leg when you walk. This patient will say no. Then we go to ruling out secondary causes. So hyperthyroidism, you know the questions now. So any recent change in your weather preference, any change in your bowel habit or body weight. Have you noticed any lump on your neck? Then kidney condition. So we have renal artery stenosis, CKD, and PCKD, which is chronic kidney disease or kidney failure and polycystic kidney disease. So how is your water works? Water works is the urine. Any reduction of urine output these days? Any headache? Any frequent leg cramps? Any swelling in your body? Any lump or bump on your tummy? Any family history of kidney conditions? So these will cover all of them. So how is your water works? Any reduction of urine output. So patient who has chronic kidney disease, they can have oliguria. If you're thinking of glomerulonephritis, you can also say, have you noticed any blood in your urine? Then headache, leg cramps, swelling, these are all feature of chronic kidney disease. Lump or bump with family history, that's for PCKD. Then we have Cushing syndrome. Have you noticed any change in your face? Any muscle weakness or any easy bruising? So we know that patient with Cushing, they develop moon faces and they get their proximal muscles become very weak. So they say that I have difficulty to climb the stairs, or I have difficulty to comb my hair or do any above shoulder activities, because their proximal muscle, which means shoulder and pelvic girdle, can become quite weak. Okay, so that's only question we can ask. For pheochromocytoma, same question. Any episodes of headache, flushed face, excess sweating? Then we have sleep apnea. So do you feel fatigued or tired, especially in the morning, even after having a good night's sleep? Anyone complain that you snore while you sleep? So that will cover OSA. Then ask about stress at home or work. If it is a female patient, do not forget 5P, which means we ask about when was your last menstrual period, because we really, in female reproductive age, we need to make sure that we know that they are not pregnant. That's really important. So when was your last menstrual period? Is it regular or irregular? After that, we ask that, are you sexually active, which means partner? If the patient say yes, then we ask about, are you taking any contraceptives? This patient will say, yes, I take oral contraceptive pill. Then you need to ask a little bit that how long you are taking it. Have you missed any of this pill recently? Just to rule out possible pregnancy. Is there any chance that you can be pregnant? And previously we had Pap smear, which is now replaced by cervical screening test. For this particular case, it is not relevant. So at least ask, when was your last menstrual period? Is it regular, irregular? Are you sexually active? Do you take any contraceptions? If yes, then find out which one, how long. Any chance you can be pregnant. Then quickly ask about smoking, alcohol. These are very important. Any social drugs. Ask about any medications. And ask about any past medical or family history. Okay? So that's basically all that we need to ask for hypertension causes. In this case, you will not find out anything except patient is taking oral contraceptive pill, and that is the cause. So you will say, thank you so much for all the information, Jenny. From history and examination, most likely you have got hypertension, which is having an increased pressure in your blood pipes. Jenny, please don't get scared because it's not an uncommon condition. Most of the time, we can't find out the underlying cause of it, but in your case, I am suspecting that it can be due to the oral contraceptive pill that you're taking for the last few months. But it can be due to other causes as well. Then you give all the differentials. In here, the differentials are the causes of hypertension. So you say that why it is unlikely. That's why I would like to organize few blood tests to rule out these conditions, such as I'm going to do a full blood count, liver kidney functions. I'll check your thyroid function, blood sugar, and lipid profile. If everything seems to be normal, then we can be sure that it is the oral contraceptive pill that's causing the high blood pressure. Left untreated, this can cause serious complication that can affect your heart, brain, kidney, and even your eye vision. But you are too young and you do not have any cardiac risk factor. So if we can manage your blood pressure, then you should be fine. There is nothing you need to worry about. So most importantly, I would like you to stop the oral contraceptive pill and please make another appointment with me to discuss other contraceptive options. For now, if you are being sexually active, please use barrier methods such as condom. Please make sure to follow healthy lifestyle, which means maintain ideal body weight, go for a walk at least every day for 30 minutes, do some exercise, make sure you eat healthy balanced diet. I'll give you some reading materials to know about high blood pressure, and I would like to see you after the blood test is back. Do you have any questions? Okay, so very nice and easy case. All you need to do is to find out the cause of this. Now remember, it's not always that in exam it will be oral contraceptive pill. It can be that patient has a obstructive sleep apnea. It can be that patient has like very bad lifestyle and it is an essential hypertension. So don't just think that it is going to be a secondary hypertension always. I have got a 16-year-old, like a 16-year-old whose blood pressure goes to 160, and that patient is like weighing about 150 kilo. So there are patients like that. So you can't just say that, yes, it's a 20-year-old, it will never be a essential hypertension. It can be, but you need to rule out secondary causes in this patient. They are too young to get hypertension, right? So for this group of patient, yes, we will do the blood test. Okay, so do the blood test, make sure that you stop the oral contraceptive pill. You don't need to talk about a lot of complication because once you stop the oral contraceptive pill, the patient's blood pressure should come down to normal. Okay. So this is the management of hypertension. I want you to know that how to manage hypertension in a real life because if this case comes in exam, they can give you a case which has hypertension and it is confirmed, and then they can ask you that discuss the management of hypertension for this patient. And I'm sure most of you still don't know how to treat hypertension. You will start medication for everyone, but that's not how it works in Australia. So let me explain how we manage hypertension in here. So first of all, confirm hypertension. The first reading is usually disregarded. The automated clinic blood pressure is determined by calculating the average of the second and third reading. That means you got first reading high. Will you just say that, yes, that's it? No. The first reading can be high in a lot of patients. So you do a second and third BP, and the average of that is what you will take. Many patients have home blood pressure monitoring machine, and in that patients, you can always ask them that, can you take some home blood pressure reading and bring it back to me so that I can check how is your home blood pressure looks like. Because many can have white coat hypertension. That means in the clinic it is very high, but when they are at home in a relaxed environment, their blood pressure is normal. So when you get a high blood pressure for the first time in your GP clinic, ask them, do you have a machine at your home? Then if yes, then you can say that, well, measure some blood pressure morning and evening for a week and bring it to me and I'll have a look. That's the first thing we would do. The next thing is, let's say you have confirmed that yes, this patient has high blood pressure. So what is the value that we call hypertension, guys? What's the value? Is it 120, 130, 140, 150? What's hypertension? Yes, it is more than 140/90. That's what we call hypertension. Below that, it's fine. So when to start blood pressure lowering treatment according to Australian cardiovascular risk? So when we think that, do we need to start antihypertensive for this patient? The first thing we look is this cardiovascular risk assessment. So there is a cardiovascular risk assessment chart that we use, and we put all the things, patient's age, sex, smoking status, their cholesterol ratio, their systolic blood pressure. So we put all of this information in that cardiovascular risk calculator, and the risk calculators say whether the patient is low risk, intermediate risk, or high risk. So what is this low risk? Low risk, if the cardiovascular risk calculators say that it is less than 5%. Less than 5% is a low risk. 5 to 10% is intermediate risk. Now, this is the new Australian Heart Foundation guideline. If you look at John Murtagh, you will see totally different ratio. Please do not do that because Heart Foundation has changed this recently, just in the last 1 year. And if it is more than 10%, that's a high risk. So for patients at high cardiovascular risk, we start the patient with blood pressure treatment in addition to the lifestyle modification. So if a patient has high cardiovascular risk, for that patient, yes, starting the blood pressure lowering treatment is indicated straight away, along with the lifestyle modification. If it is intermediate risk, consider adding a blood pressure lowering treatment in addition to the lifestyle modification. But the sensible approach is give them at least 3 months to try lifestyle modification before you start the treatment. And then if it is a low risk, then you should start with lifestyle modification for 6 to 12 months. And if still it is consistently high, then we can try a medication. So before we start medication, especially for hypertension, it's not that, yes, you have got more than 140/90 blood pressure, I'm going to start you with blood pressure lowering medication. It's not how it is. So you find out what's their risk of cardiovascular problem. If they have low risk, you just go for lifestyle modification. Intermediate risk, usually 3 months lifestyle followed by treatment. And if it is high risk, then yes, you can start the treatment right away. Always remember, lifestyle management is the most important part of managing hypertension. So lifestyle modification include regular aerobic exercise, such as walking, running, swimming, dancing. These are all aerobic exercise, which is very good for cardiovascular health. Reduction of alcohol intake. You don't need to ask the patient to stop alcohol. And we don't normally do that. Okay? So they can drink alcohol, but there is a standard drink that we need to follow. Stop smoking, no added salt in the diet, healthy eating, and weight reduction. The most important thing is reduction of body weight. Even a 5 kilo weight loss can reduce the blood pressure by 7 millimeter, which is a lot. So when you talk about lifestyle modification in a hypertension patient, talk about this. This is according to ETG guideline. These are all our medication of choice. If we are thinking to put a patient on medication, we can choose from ACE inhibitor, ARB, calcium channel blocker, or thiazide diuretics. So A, C, D. That's our first line antihypertensive. Starting drug treatment. So let's say we want to start a treatment for hypertension in a patient. How we do it? Starting drug treatment, there are two approaches. One, we can use a single drug, or we can use two combination drug at a low dose. Especially for high cardiovascular risk patient, we can use combination, like we can use the ACE inhibitor plus a calcium channel blocker at a low dose, or we can just start with the ACE inhibitor as well. Depends. Especially if it is like, if the blood pressure is quite high, like 180 over 100. Yes, that patient is reasonable to start a combination. Someone's blood pressure is 160. Reasonable to start just a single treatment. So it's all about how you see the blood pressure. Patients with elevated blood pressure commonly require 2 or more drugs to reach their blood pressure target. So how we adjust our blood pressure medication? So to allow time for optimal effect of any initial treatment, changes to the drug therapy should be considered 4 to 6 weeks after starting treatment. In John Murtagh, it is written you need to wait for 3 months before changing the blood pressure treatment. But the new guideline, which is the therapeutic guidelines, say that no, you don't need to wait for 3 months. You can change the medication even after 6 weeks. Because blood pressure, usually if a medication is supposed to work, it will work within 6 weeks. So after 6 weeks, you bring the patient back. If the blood pressure is still a little bit elevated, you will change the medication or increase the dose of the medication. So let's say we started a patient on a monotherapy, maybe just ACE inhibitor, like ramipril. If the blood pressure target has not reached after 4 to 6 weeks, do not stop or change the initial drug, but add a low dose of a second drug from a different class. So best idea that you use a CCB or a thiazide diuretics. So instead of increasing the dose or changing this medication, just add a second class of medication. This is more effective. Okay. Now let's say patients now taking 2 drugs, but still blood pressure is not achieved. Then in that case, you can increase one of these medication one by one to maximum, and then again increase the another one gradually to the maximum. So every 4 to 6 weeks, you can gradually increase the first drug to the maximum dose. Still blood pressure is not getting down, then you increase the second drug one by one. That's how we manage hypertension. Okay, and that's how you should also do it. Any questions? There is a reason why I'm explaining it. You might think that, is it important for exam? It is, because just very recently, there is a case where patient came with a significantly elevated hypertension. So if you don't know what is the normal blood pressure management, how you are going to manage a patient who has significantly elevated hypertension. So the first basic is to know that how you are going to treat a normal patient who has moderate hypertension, not severely elevated. And by severely elevated, I means more than 180 over 110. That's what we call severely elevated hypertension. Do you guys understand me so far? Means the management of hypertension, that how we are going to manage? The calcium channel blocker that we use is not the rate limiting. That means it's not verapamil diltiazem. We use the amlodipine, larcanadipine, those ones. Okay, now we move on to the main thing that I've seen that it is important, how to manage a severely elevated blood pressure patient. When we get a severely elevated blood pressure patient, we look at these three things. Is it just elevated BP without any symptom? Is it hypertensive urgency? Or is it hypertensive emergency? So severely elevated BP without any symptom, and the symptom means headache, dizziness, chest pain, shortness of breath, those are symptoms. So this patient doesn't have any symptoms, just elevated BP. In that patient, it is not like that it is an immediate threat to life. So this patient you can treat in a GP setting. You don't need to send them to hospital. The guideline is that you should achieve initial blood pressure reduction. So your goal should be at least reducing this blood pressure back to 160. Like that. That should be your goal. And you will be achieving that in 1 to 2 days. And that is enough. Okay? And how to do that? So severely elevated blood pressure without any symptom. So first of all, let's say in the emergency department, we found that patient who has very high blood pressure. We found out that patient doesn't have any symptom. So we keep the patient under observation. If this patient was already on a blood pressure medication, then we will just give the regular drug that he or she was on before. If not on any drug, then we will add a new antihypertensive if BP does not settle after a period of observation. So that's what is written in ETG guideline. Before starting the treatment, allow a period of observation with repeated measurements to see if BP settles without any intervention. So if a patient was not on any antihypertensive, then you keep the patient under observation for a few hours with repeated measurements. See if the blood pressure is settling down. Still not settling down, then you start an antihypertensive medication. And then you ask the patient to review with his GP next day. If it is in the GP setting, then you already know the patient. You will know whether the patient was on a medication or not. In a GP setting, you can still put the patient under observation in a treatment room for a few hours and see how they go. And still it is elevated, then you can start the medication and bring the patient next day to see how he is doing. Okay, so this is the management for severely elevated BP without any symptom. Now we have got a patient who has symptom. Same elevated BP, but patient has symptoms. That's called hypertensive urgency. Is there an immediate threat to life? No. But in here, our time frame to achieve initial blood pressure reduction is hours. It's not days anymore. So we need to bring it down. And this is usually treated in a hospital setting. So hypertensive urgency is a severe persistent blood pressure above 180/110 associated with significant symptoms such as headache or dizziness with mild to moderate end organ damage. End organ damage usually end organ means hypertensive retinopathy, then hypertensive nephropathy. Or if they have heart attack like myocardial infarction. So these are all end organ damage. While hypertensive urgency is not immediately life-threatening, referral to hospital is required because they will need blood test, they will need X-ray, they will need an ECG, and they might even need an echocardiogram to exclude any end organ damage. So this patient need a blood test to check their kidney function, liver function, do a ECG, make sure they don't have any ischemic heart disease. Okay, so to find out organ damage, we need to send them to hospital. Management is usually with oral treatment, aiming for relief of symptoms and a slow reduction of blood pressure to a safe level over several hours. It's not like we need to give him IV antihypertensive to bring it down super quick. It's gradual reduction. So hypertensive urgency, now that is, I believe that is the case that is coming. So in hypertensive urgency, if it is an emergency department setting, first thing is, if patient already was on a blood pressure medication, give that medication if they haven't taken it. If not on any drug, who has not missed any dose of their regular drugs, so either patient was not on any medication or patient was on medication and did not miss any dose, for them, give a oral amlodipine 5 milligram and monitor the patient over the next 6 to 24 hours and see how the patient doing. Because amlodipine can lower down the blood pressure steadily, and that is the treatment of choice. Okay? So if it is a hypertensive urgency, the main thing is you will see the question will say, you will find out the blood pressure is above 180 over 110, and patient will have the symptoms. In an ED setting, you admit the patient, call your senior, okay, and then do this blood test, ECG, make sure there is no end organ damage, and find out whether the patient was already on a medication and if they missed that medication. If they missed that medication, give that medication straight away. If they were not on any medication or they did not miss their regular medication, then you need to start the patient with amlodipine straight away. Okay? There are a few other things I have written in here that if we need to go for rapid reduction of blood pressure, especially if the patient's symptoms are severe, like patient has developed hypertensive encephalopathy, for those patients, if we want to reduce the blood pressure within 2 to 3 hours, then we can go for captopril, clonidine, larcanadipine, prazosin. These medications can be tried if we want to go the blood pressure super fast. And the last one is hypertensive emergency, where the blood pressure goes to above 220 over 140. This is significantly elevated BP. They will have symptoms, they will have significant end organ damage. And this patient's blood pressure needs to be reduced within minutes. They are usually treated in hospital ICU or CCU, not usually an exam question. I have kept it in here. If you want to read it, you can read it. But just remember, if it is a hypertensive emergency, it is a life-threatening event, immediate hospitalization is needed, cardiologist should be involved, and this patient should have the goal will be to reduce the blood pressure no more than 25% in the first 2 hours. So gradual reduction in the first 2 hours, and the treatment is IV hydrolagin or IV clonidine or even IV metoprolol. These are the treatment. It's very unlikely that this will be given in the exam, but still it's good to know. Most likely it will be either the elevated BP without any symptom or hypertensive urgency. This is usually the case. Okay? Did you guys understand how to manage these two? And these are all the end organ damage. So pulmonary edema, adrenal crisis, hypertensive retinopathy, nephropathy, or intracranial hemorrhage. So this is what we call end organ damage. So if I ask one of you to explain or just to say that how would you manage a patient who comes to you with hypertensive urgency, what would you say? Anyone who wants to just explain what is hypertensive urgency and how you're going to manage this patient in an emergency department? Yes, so you need to explain that, yes, you have got high blood pressure, and in your case, the blood pressure is very high, which is above 180 over 110, and you have symptoms. So we call it hypertensive urgency. And even though it is not immediately life-threatening, it is something that we are very concerned, because left untreated, this blood pressure can cause significant damage to your heart, kidney, brain, and also to your eyes. So I'm going to admit you to the hospital. I'll call my senior, and a heart specialist will come and review you. In the meantime, I'm going to do this test. For the management, the specialist will most likely start you with a medication called oral amlodipine, which is a medication which can gradually lower down your blood pressure. And will keep you under monitoring for the next 6 to 24 hours to see if the blood pressure is dropping. And then we will go from there. That's usually the treatment. Okay? All right. Moving on to antihypertensive non-compliance case. So this was the case I was talking about. This is also quite important. So we have got a 45-year-old patient came to you for vaccination, but nurse got her blood pressure, found it is very high. She was given candesartan previously. So candesartan, it's a angiotensin receptor blocker. Nurse advised the patient to talk to you, and you found that she recently moved to your place. So take history for 4 minutes and counsel the patient accordingly. So this is a patient who was already diagnosed with hypertension, and she was given antihypertensive. And when you talk to her, you will find out that she's not taking the medication anymore. So that is an antihypertensive non-compliance case. That's one question. There is similar question where you are in a GP, a patient who was diagnosed with hypertension 1 year ago came in for follow-up. She is non-compliant on her antihypertensive medication. She has been drinking 6 standard drink daily for 5 years. Your colleague did MMSE, which is mini mental status exam, and find out that patient has short-term memory loss, long-term is intact. So this is a case which is alcohol-induced brain injury causing the dementia. Because of dementia, patient is forgetting to take the medication. So that's a different case. Take a history and counsel the patient about general and specific measures to enhance the antihypertensive compliance. So these are the two cases which comes back to back, and you need to know both of them. So case 1 stopped blood pressure on her own as she did not have time due to moving places. She's stressed with her family life and she's going through a phase. Case 2 stopped as she keeps forgetting to take the medication. Let's talk about the case 1. So first you go in, introduce with the patient. So you'll say that, hi, this is Dr. Arshan. Very nice to meet you, Sarah. I understand from the note that you are new to this place. How is everything going? Are you enjoying here? Yes, doctor. So I appreciate that you came here for the vaccination. Have you got any pain or any problem with that? No, doctor. Well, Jane, the nurse found that your blood pressure is on the higher side. Can I ask a few questions related to that? Yes, doctor. See that initially we started with how is the moving? Are you enjoying the neighborhood? You had a vaccination. Are you okay? So do these things always. Make a rapport. After that, you can start asking questions about the blood pressure. So you can say, I can see you were previously prescribed a medication for high blood pressure, which is candesartan. Have you been taking the medication? No, doctor. Well, how long you are not taking it? When did you get diagnosed? How did you get diagnosed? Did you have any symptoms at that time? May I ask why you are not taking it? So we are now going to find out that why she's not taking the medication, right? So causes of non-compliance can be medicine-related problem, can be the doctor who did not explain that why you need to take the medication, or patient might not believe that this medication is helpful. So first, medication related. Any side effects from the medication, that's why you stopped it? Any issue with the cost or understanding of the prescription? Then doctor related, did your doctor advise that why it is important for you to take the medication? Did the doctor advise what can happen if we don't treat it, or what can happen with untreated high blood pressure? And for patients' belief, what is your view about your condition and about this medication? Some patients can have a lot of strange belief that they don't like to take medication, everything will be fine, they will take lots of natural roots, herbal medications and all. Try to find that out. Do you think this drug is beneficial? Are you trying any alternative treatment like any herbal medicine or any other natural medications? So that's your main finding, that why the patient is not taking the medication. Is it related to the medicine? Is it related to the doctor did not explain why you should take it? Or if the patient's belief is having the problem, okay? Once you have done that, assess if there is any damage already happened because the patient is not taking the medication. So do you get any chest pain, shortness of breath, or any palpitation? Any swelling of your ankle or foot? Any vision problem? Have you noticed any change in your waterworks? Then quickly find about their lifestyle. So do you take healthy diet? Do you smoke alcohol? Do you exercise regularly? How is your mood these days? How is the home situation? Any financial issues? Any stress at home or work? This is always important in a hypertension patient. Okay, because you will find out when you ask this that yes, moving the house is being very stressful. It's new work, new place, everything is making me very stressed. So that's always important to find out from the patient that is there any stress going on. And lastly, finish with past medical and family history. Okay. So that's basically all the history that you need to ask for non-compliance case, especially the case 1. Now in the case 2, we will explain like this. Thank you, Jane, for all the information. Jane, as you already know, you have high blood pressure, which means that your blood is pushing too hard against your blood pipes. Imagine your heart is a pump and your blood vessels like your garden hose. If the pump pushes too hard for too long, it can damage these hoses. That's what happens in hypertension. Your heart works harder. Over time, it can cause problems like heart disease, stroke, kidney damage, and many more. See this explanation, like we are trying to relate hypertension with something a patient understand. If you can do that, your patient will love you. Your patient will understand. As I said in the first class that Australian loves garden. So if you can explain in their own term, that's how it's really means a lot for a patient. So heart is a pump, right? Blood vessels looks like a pipe, like the hoses. If the pump pushes too hard for too long, it can damage the hose or the pipes. That's what happens in hypertension. Your heart works harder. Over time, it can cause problem in everywhere these blood pipes are going. It can damage the heart. It can damage your brain, causing a stroke, kidney, and many more. You usually will not feel it because it is called silent killer. And years and years, there will be no symptoms. But if you leave it untreated, there will be a time when you will start feeling symptoms when it will be too late. You will start to get chest pain, shortness of breath, blurry vision, increasingly tired. And that's why you need to be on the medication even if you do not feel any symptoms at the moment. That's how you motivate the patient. You have to explain why it is important, because most of this patient will feel that I feel completely fine, so why I will take the medication? First, I would like to assess your risk of a cardiovascular event, that is a stroke or heart attack, using a risk assessment chart. For that, I will need to check your cholesterol level as well. So I'm going to arrange a healthy heart check for you that will include a baseline ECG. I will do some blood tests, including your blood count, your kidney function, blood sugar, and a lipid profile. Because if we need to put the patients into that chart, we need the cholesterol level. We need the ECG to see if they have got any kind of left ventricular hypertrophy. So, and then we can put all of the things in that chart to find out the risk. So that's what we have explained in here. But roughly, you have moderate risk based on your age, your blood pressure, and sedentary lifestyle. So please start taking the medication. Now, this is all like just an assumption, because you will find out patient has high blood pressure, age will be mostly like 50, 60, sedentary lifestyle. So you can always say that I feel like you are in a moderate risk. So please start taking the medication. And based on the other blood test result, I will decide whether you need further assessment of your heart, including a CT calcium score to check how much calcification or fat has accumulated in your heart blood pipes. So this is a thing that, like under Australian healthy heart check, we can offer a patient this kind of things. If you think that a patient is moderate to high risk, then you can find out more. CT calcium score is a very fast test where we send the patient like for a CAT scan or CT scan of the heart, and it can say that how much calcification has happened already in their heart. And based on that, we can decide whether we need to put the patient on a statin or aspirin. Okay? Along with the medication, please adopt healthy lifestyle. Talk about all of them. I understand that moving to a new place can be quite stressful. So take your time and gradually get adjusted. You can try some relaxation techniques like mindfulness, yoga, meditation. Please document your blood pressure in a diary for a week and also show me so that I can see that the medication is working for you. Here is a reading material for further insight. I would like to see you in 1 week with the blood pressure diary, and also we will talk about the blood test report on that appointment. Do you have any questions? Okay. See that this is how you need to make sure that you explain you have got high blood pressure. You talk about why blood pressure management is important. Talk about the cardiovascular assessment chart. Send the patient for blood tests, especially cholesterol level. And then talk about, yes, you need to take the medication and healthy diet. Talk about the stress, and then bring the patient back with a blood pressure diary. Okay? Make sense, guys? Now, the second case, which was forgetfulness case, that case we will discuss in our psychiatry case where the patient has dementia. So when we discuss the dementia, this will make more sense to you because this case is actually dementia plus hypertension. So I'll not go into this case today, but you can give it a read also, but it will make more sense when we discuss the psychiatry dementia, and then we can come back to this case again, okay? The last case, which is also under the hypertension cluster, is this ambulatory blood pressure monitoring case. So I have seen this case not a lot, but if it comes in exam and you don't know anything about it, it can become the end of that case. So it's good to know. So we have got a 45-year-old male patient presented in a GP practice to discuss his BP readings. He presented last time in your clinic a few days back. You checked his blood pressure. It was 154/92. You asked him to check his BP at home, and here he has come with the result with average blood pressure between 120 to 80, 120/80 to 150/85. So there is a significant discrepancy in here. Fundoscopy showed grade 1 retinopathy. So the task is explain to the patient what is ambulatory blood pressure, explain the implications of high blood pressure, and which investigation you would like to order. So this is one of the cases where you don't need to ask history from the patient. All you need to do is to explain everything for 8 minutes. So first of all, you greet the patient, appreciate the patient for bringing the home blood pressure reading. Say that I really appreciate you have done it. Thank you for it. Now I can see from your home blood pressure reading that your blood pressure is staying between 120/80 to even it's going up to 150/85. So John, sometimes when we get this kind of this kind of discrepancy between multiple readings in your blood pressure, we can't be fully sure whether you have high blood pressure or not. That is the time we would like to send you for a confirmatory test called ambulatory blood pressure monitor. In ambulatory blood pressure monitor, we will put a device which is like a blood pressure cuff on your arm, and you will keep that device on your arm for 1 day. And that cuff will check your blood pressure frequently whenever you are working, whenever you are sleeping. So it will just do the blood pressure multiple times, and it will give us an average blood pressure in the daytime and nighttime. And that is the only way we can confirm whether you have high blood pressure or not. Because sometimes we find that some of the patient can have a condition called white coat hypertension. That means when you come to the clinic, because clinic can be a stressful environment, it can release certain chemicals from your brain, which can cause a transient rise of your blood pressure. But in reality, your blood pressure may be completely normal. So when we see that there are lots of changes in your home blood pressure, and even in the clinic when we are checking it, it's going really high. So that's why we are going to send you for this ambulatory blood pressure reading. If it confirms that yes, you have high blood pressure, then we are going to manage it accordingly. David, hypertension is also known as silent killer because it can sometimes cause severe damage without causing any symptoms at all. For example, it can affect your heart, right? Causing enlargement of the heart. It can cause chest pain or even a heart attack. It can cause brain damage by causing bleeding inside your brain. It can damage your kidneys and eyes. We have already found some early changes in your back of the eye. So it's very important that we control your blood pressure so that we can prevent it from further damage. It can also reduce the blood supply to your legs, resulting in pain during walking. I know it sounds very scary, but David, if we can manage it, if we can make sure that yes, you have high blood pressure and we can treat it accordingly, you will be fine. Most of the time, there is no known cause. In only 5 to 10% cases, there might be a cause. So to rule out any secondary causes and also to assess your heart risk, we are going to arrange some investigation. So you talk about all these investigation. Also arrange a urine test to check if you are losing any protein in the urine. Because hypertension affecting the kidney, the first thing can be that you will get microalbuminuria. So if you check the protein in the urine, if you find protein in the urine, that can suggest that yes, the blood pressure is affecting the kidney. Once the above investigations are done, I will assess your risk of having a stroke or heart attack on a 5-yearly cardiovascular risk assessment chart, and then I will manage you accordingly. Given that we have already noticed some changes in your eyes, most likely, if we confirm you have high blood pressure, then most likely you will need to start a medication. I will also send you to an eye specialist for further assessment, but I want you to know that there is nothing to scare. With appropriate management, we will be able to protect your eyes from any further damage. In the meantime, please make sure to follow a healthy lifestyle, so explain it, and then follow. Pretty simple, but if you don't know, you can mess it up. Right? So mainly it's more or less the same explanation of hypertension everywhere. So just remember, first you discuss what is hypertension, why it is important to treat. So talk about all the complications and definitely reassure after that. And then send the patient for some investigation, talk about cardiovascular risk assessment, and then whether you think the patient might need medication, and definitely talk about lifestyle. That's mainly the gist of it, right? If you can do that, you're fine with these cages. So these are all the hypertension cages that comes in exam. I'm sure you have not seen this much cages, even if some of you might be even our past student, some of you might be our, like, in the middle of your preparation. I'm sure you haven't done a lot of these cages, right? But these are cages which comes in exam, so definitely worth going through them. So that's all about our class tonight. I hope you enjoyed the session. Please prepare for the cardiology using these 3 classes that we have taken. And we will be doing a cardiology role play session in our next class, which will be on Sunday. And Sunday is our last class on free 2-week session. Okay. And after that, we will start our full clinical course in the full rhythm. Do you guys have any questions? No? All right then. So we'll finish it here. Link for previous classes, Vivek. So all our previous classes are given in our Facebook group. So are you in our Facebook group, Dr. Vivek? No? Okay. The first thing I will suggest, I'll show you what that Facebook group looks like. So if you go to our Facebook group where we mainly post most of the things, so you'll be seeing this first aid AMC clinical. So just write it and you should be able to join it. And in the first aid AMC clinical, if you go to the featured section, in the featured section, we normally keep all the recorded classes. So you scroll down a little bit. So this was our last class of cardiology. So that's the syncope cluster that we have taken. And if you go down, you will see that this was the psychiatry review session. And I'll make sure that all the recorded classes are here as well, because I think some of them are not here. So I'll put them in the featured section. Oh, it's in here. So this is one of the random role play class that we have taken. So I'll make sure all of these comes into the featured section as well. Okay. There is no dedicated group, but when you join the course, Dr. Aryan, the course will give you study partners, because that's how usually people find study partners. Study partners is not something that we can find for you, but you can always talk to other people in the course, and you can always catch up and make a buddy from there. That's how everyone do it. Dr. Syra, so the installment payment is due in 2 months from the start of the course. And how long you have access to the course materials? So it depends on what you actually purchase. There are several options in the subscription plan. If you have purchased the 10-month access, then you get 10 month. If you purchase 15 month, then you get 15 month. And I want to show you that if you see one thing, that just in our last 2 months, these are all of our students who passed the exam. And this is a significant improvement. This is a significant result. As part of clinical exam, especially April and May was very difficult exam. I've seen some of the cages quite difficult, lots of new cages, and you can see that that doesn't actually stop our candidates to pass the exam. All of this, and like almost most of them, has passed in the first attempt. It is a very, very good result as part of first aid AMC clinical. So I want you to know that if you follow our guidelines, you will be among them at once. But you need to do those hard work these guys has done, and I'm sure you'll pass the exam in no time. So I want you to understand that First Aid AMC Clinical has the highest number of passing candidate in almost every month. And we prepare our students in that way. So even if there are cases which is very difficult, they can pass that case because they know how to approach, they know how to do a case, and that's all that matters. Okay. No, you can't do that, Dr. Saira. So if you subscribe for 10 months, that is all that you will get. You can't extend to 15 months after that anymore. No, there is no options because the software is actually created in that way. We can't actually do anything. The software will just deny the access. Okay. All right, everyone. So that's it for tonight. I hope you enjoyed our sessions, and please prepare these cases because we'll be doing some role plays. Thank you all. Have a good night. Take care.